syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMD Demystified podcast.
Welcome. Glad to have you here. You are about ready to witness the next episode, live stream of TMD Demystified. I am Tony Urbanek. For any newcomers or for viewers that watch this live stream that is then recorded and made available, I want to first make it clear that anyone is should and able to ask questions. I look forward to questions, comments, even criticisms on this live stream, because TMD, temporomandibular joint disorder, is a very controversial disease, creates a lot of controversy, and a very disruptive disease personally from patients. And they deserve some facts rather than nonsense about this disease. And again, for those of you who are not familiar with me, I am an oral and maxillofacial surgeon practicing in Middle Tennessee for more than 50 years. I do not do surgery anymore. I quit doing maxillofacial reconstructive surgery roughly 5 years ago and devote my entire career now to the non-surgical treatment of temporomandibular joint disorder, and actually discovered, found, uncovered, because it was always the same. There was nothing special about this as to what the actual mechanism is. We call it the pathophysiology. Doctors call it pathophysiology, and public call it mechanism that creates a disease. The profession, the dental profession, wants to make this complicated. They have even created a specialty in dentistry to treat this disease. And my last episode on my podcast and blog addressed that issue, that we don't need specialists to treat this disease. You just need some dentists who understand the disease, and it can be treated relatively easily. And you need to be a dentist because the solution has to do with a very simple oral orthotic device that unloads the temporomandibular joint and makes the pain and painful and non-painful symptoms go away. So as it worked out, the dental profession was given the responsibility to treat this joint as opposed to all the other joints in the body. The orthopedic surgeons treat all the other joints in the body, but they gave away this joint to the dental profession to treat because it's attached to the jaw, which is attached to the teeth. And they thought, I think that probably dentists I need to handle the temporomandibular joint. And over the past 50, 60 years, the dental profession has made a mess of it, an absolute mess of it. So that is a little primer. I'm an oral maxillofacial surgeon. I'm a double degree oral maxillofacial surgeon with a dental degree and a medical degree, additional training and a degree in cell biology and anatomy, and 2 years as a fellow with the National Institute of Health, National Institute of Dental and Craniofacial Research, to do research on facial growth and development, which was a large part of my practice in treating facial growth problems. And actually, the temporomandibular joint comes into play there because the temporomandibular joint is the primary growth center of the entire face. So let me make that clear. These joints the face grows in many different ways. That's a whole topic. You can write textbooks, and there are some very good textbooks written on that topic. But the temporomandibular joints are the primary growth centers of the entire face. There are other things going on that cause the facial skeleton to grow, but the TMJs are the primary growth center. And so it stands to reason that you need to take care of these joints as the person develops, for sure, and after they are fully grown. You can damage these joints in 3 different ways: bruxism, acute trauma, and functional malocclusions, which then cause all the symptoms. All right, with that as a preliminary for today's discussion, I encourage questions. I will try to answer questions as they come up. If there are no questions, we're going to run this about 25 minutes because I have to attend one of my grandchild's football games in about 30 minutes, so I'm going to be a little late. That's why I'm dressed the way I am, to get out in the heat. So let's talk about the topic today. The topic today is TMD is a much bigger problem than expected, much bigger problem than I expected. I think it's a much bigger problem than anybody expects, and really upsets the apple cart for a lot of other people, for a lot of other professionals, for a lot of other doctors, for the pharmaceuticals in particular, who actually make their careers or a lot of money on making this problem complicated or doing things that are not effective. And I hold by that. I will state that as the truth. So let me give you a couple facts, first of all, about why this is a much bigger problem than expected. And this doesn't, what I'm about to say, does not completely cover the entire waterfront as to the different reasons, but there are 2 particular diseases that are misdiagnosed constantly, and conflated with temporomandibular joint disorder, misdiagnosed as something else when it really is TMD, temporomandibular joint disorder, confused with. It's not because the doctors want to be confused, it's just that TMD has had such a terrible track record within the dental profession, is the dental profession has a responsibility for treating this disease, whether they like it or not. They were given this to treat by the medical professions because they don't want anything to do with it. Your orthopedic surgeons, your medical doctors, your PCPs, they do not want anything to do with treating this joint because it's attached to the jaw, and because the teeth are attached to the jaws. So here's a couple facts. The TMD is constantly misdiagnosed as migraine headaches. And the second disease that is most commonly misdiagnosed is something called Meniere's disease. Meniere's disease is a disease well known to the ENT, otolaryngology profession. Definition of Meniere's disease is the symptoms themselves. If you ask any otolaryngologist, ENT doctor, tell me what Meniere's disease is all about, how do you define it? He will say it's defined by its symptoms. And it has 3 major symptoms. And those symptoms are tinnitus, which is actually ringing in the ears, ringing or buzzing. Not tinnitus, that's a different disease. That would be inflammation of something or another. Tinnitus is ringing of the ears, a feeling of fullness in the ears, like you can't hear in that ear or ears because it's full of water, and the water won't go away, like you've been swimming and can't clear your ear. That is called subjective hearing loss. And the third one is dizziness, vertigo. Vertigo is, they're not identical. Vertigo and dizziness are a little different. Vertigo is the subject feels that the room is spinning, and dizziness, you feel you are spinning. You're objectively spinning. So those three non-painful symptoms, by definition of the otolaryngologist, is called Meniere's disease. And then the first disease I talked about was migraine headaches. Now, those two diseases need to be understood from the point of view of the medical profession and the point of view of TMD. We know, everyone knows, every dentist knows who has ever had any kind of exposure to temporomandibular joint problems, temporomandibular joint patients, knows that migraine headaches, or bad headaches, are they're more properly described, and ringing in the ears, fullness in the ears, dizziness are well-known, well-accepted symptoms of temporomandibular joint disorder. Now, let me give you a couple statistics. Migraine headaches, self-diagnosed or diagnosed by a medical professional, are seen in one out of 6 Americans. 1 out of 6 Americans. And 1 out of 5 women have what they consider migraine headaches, at least one over a 3-month period. If you do the arithmetic on that, you multiply 360 million people times 20% of the population, which is 1 of 5, that is 72 million women in the United States claim that they have migraine headaches, at least one every 3 months, and some of them have one a day. Now, that's called the prevalence of migraine headaches. Prevalence of migraine headaches. 1 out of 6 Americans and 1 out of 5 females. 45% of patients with Meniere's disease also experience migraine headaches. And thirdly, Meniere's disease prevalence is 1,650,000 Americans have Meniere's disease, and 45 new cases of Meniere's disease every year. So there is a lot of Meniere's disease and a lot of migraines going on. So here's the problem. Here is the problem. The medical profession admits they do not know what causes migraine headaches. They admit that. They have a lot of theories. They have a lot of studies. There are hundreds and hundreds of studies, if not thousands of studies, trying to figure out, do studies on what causes migraine headaches. But they admit they don't know. They're just a bunch of theories. The ENT doctors admit they don't know what causes Meniere's disease. They know the symptoms, the 3 symptoms: tinnitus, subjective hearing loss, and dizziness, vertigo. If you go into an ENT doctor with 1 or more of those symptoms, they'll do a very extensive, very expensive workup and tell you, you have Meniere's disease. And then you say, well, great, what do we do about it, doc? And he'll shake his head, roll his eyes, and say, we do not have a solution for Meniere's disease. But we know that the temporomandibular joint inflammation of the joint will create bad headaches that can occur all the time, and have the usual things that go along with migraine headaches, like visual disturbances. Aura isn't a good example. And so the medical doctors misdiagnose migraine headaches and Meniere's disease all the time, when it is actually temporomandibular joint disorder. This is a huge problem. That is why I named this episode, TMD is a much bigger problem than expected. When I got into the research, when I stopped doing temporomandibular joint surgery 15, 16 years ago, which I did because I couldn't predict the outcome. When I did temporomandibular joint surgery, 2/3 of the patients were helped over a long period of time, and 1/3 of those patients that I did surgery on, temporomandibular joint surgery, would be back within 6 months to 2 years with the identical symptoms that they came in with to see me to help them as a surgeon. So I quit doing surgery for that reason. I couldn't look at the patient and tell them, I'm going to fix you, I'm going to make your symptoms go away, when I knew that 1/3 of the time you'd be back within 6 months to 2 years. And I started doing my own research because of my broad experience in medicine, dentistry, and science investigations as an investigator for the National Institute of Health with my own research project and grant. And I did the research, and I discovered the actual pathophysiology mechanism for temporomandibular joint disorder. So it's quite obvious that the medical doctors can't tell you what causes migraines, and the otolaryngologist can't tell you what causes migraines, but I can tell you that if you treat the chronic inflammation within the temporomandibular joint, the migraine headaches, what were misdiagnosed as migraine headaches, or the one or more of the 3 symptoms of Meniere's disease, ringing, fullness, dizziness, will diminish and go away if you treat it correctly by making the inflammation within the temporomandibular joint go away. If you just treat the symptoms of, I have a pain here, so we put some Botox in here, or you do pain here, so you do some dry needling in the neck, or certainly if you put patients on drugs that do nothing more than suppress the entire nervous system, you're not going to go anywhere. You might get some temporary symptomatic relief, temporary at best. I mean, when I did surgery, I just told you, when I did surgery for 36 years, over 2,000 cases, half of them open joint surgery, half of them through an arthroscope, but 1/3 of my patients would be back, and those statistics were not good enough for me, which is the reason I quit doing surgery on the temporomandibular joint and did the research to actually figure out the mechanism, the pathophysiology that causes this disease. So if you have temporomandibular joint problems and go to your medical doctor, it is highly likely, if you come in with frequent or recurring headaches, you're going to get a diagnosis of migraine headaches and be put on some kind of medication. And if that medication doesn't work, then you're going to be put on a second medication. If that medication doesn't work, you're going to be put on a third medication. And if that medication doesn't work, you're going to be put on a fourth medication, all of them spiking up your chances of significant, quote, side effects. Because a medication is nothing more than a treatment, a medication has nothing more than side effects, and the doctor who gives you that side effect says, I'm going to give you this pill to treat this particular side effect, but you got to accept all the other side effects that go along with it. Most physicians don't tell people that. They just tell them, we're giving you the drug for this. And if you want to find the side effects, you need to read the package insert. That is the truth. No one wants to challenge me on that, I don't think. So TMD is a much, much bigger problem. The prevalence of migraine headaches is 1 in 5 females, 72 million women. We do not know. I am not saying there is no such thing as a migraine headache. All I'm saying is the medical profession admits they don't know what causes migraines. We know what causes bad TMD headaches, and the mechanism now has been explained because I've written upon it, figured it out, and now have tremendous amount of material out there for the public to look at and for my colleagues to look at. So my mission is to attempt to solve this problem by making the truth available to both the public, who are run around in circles about temporomandibular joint disorder. They run around in circles. I have so many patients. I mean, the majority of the patients we see in our practice, in our clinic, have been seen by multiple other doctors with the same symptoms that they came in to see us with and misdiagnosed as something else. Some of them even have had surgeries to help, and I'm not talking about temporomandibular joint surgeries. There are some of those, but surgeries on the neck, surgeries on the arm, surgeries on the shoulder that were misdiagnosed as something else when it actually was pain generated by the temporomandibular joint disorder. So, for completeness, let me just run down the symptoms associated with TMD. No one disagrees with these symptoms. Everyone who treats this disorder will agree these are the bona fide, well-known symptoms of TMD, which are frequent and/or recurring headaches, some of them bad headaches, earaches, neck pain, tinnitus, ringing in the ears, feeling of fullness in the ears, subjective hearing loss, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger, and/or tingling and numbness and sometimes pain, and various kinds of jaw locking. There are a few other not so common symptoms we'll save for another time, but those are the symptoms. So it's time for every participant that has a stake in this disease, the patients, the professions, and the doctors who practice these professions, to understand that, number one, this is not a complicated problem. The way you treat chronic inflammation in any joint is generally the same. If you don't want to do surgery, if you don't want to use medications, you unload the joint. If you have a bad knee, a painful knee, and you go to an orthopedic surgeon, he's going to do an expensive workup, and he's probably going to say, this knee is really shot and we need to do some surgery. It's inflamed. It's degenerating. It's so inflamed. And if you say, Doc, I don't want any surgery on my knee. Well, nowadays he would say, well, we'll do injections in that knee for a few years, and then we'll do the surgery. And he said, Doc, I don't want any injections either. I don't want the drugs. I don't want the steroids. I know the complications having to do with steroids. I don't want the steroids. What else can we do? He would give you a set of crutches, and he'd say, if you stay on these crutches, I promise your knee pain is going to go away. Now, you have to stay on the crutches, admittedly, but if you stayed on the crutches, I promise your knee wouldn't hurt. If you have tennis elbow is nothing more than inflammation of the lateral epicondyle. And the mechanism I've talked about so many times, please refer to other podcasts or other live streams that I've done, but the mechanism is the elbow gets inflamed, it sends an autonomic nervous system to the brainstem. The brainstem says, I see you're inflamed, I'm going to help you out. Tighten up the joint. Don't move the joint, and send signals to tighten the muscles that move the elbow, which are in the forearm. All of these muscles do nothing more than move the elbow. And they tighten up. And where those muscles attach to the bone, it pulls on the pain receptors called nociceptors, and that is where it hurts, in the forearm, in tennis elbow. This is the cause, inflammation in the joint. But what happens is patients complain of pain in the forearm going all the way into the wrist. That's called tennis elbow. And the solution for tennis elbow, if the patient doesn't want surgery, which they really shouldn't have, the solution for tennis elbow is really self-evident. You put the patient in a sling, and they can take some nonsteroidals too. That's helpful, but nonsteroidals run out of steam after 2 weeks. They don't work anymore, and all they do is tear up your stomach. But you put the arm in a sling, and tennis elbow gets better. Your forearm quits hurting. So how do you put the temporomandibular joint in a sling? You unload the joint by a device that separates the posterior teeth carefully, long enough, in a device that the patient can speak with in their mouth. They can wear 24/7 for a while. The protocol is 2 months, 24/7. nighttime only the rest of your life. There are a few variations on that, but that simple protocol handles 85% of the patients that come in to see us. 15% of the patients find after they go through the first 2 months, so 24/7, there are times they need to put it in more. What are those times? When they open widely, when they go to the dentist, yell at the dog, sing in church, they open widely, they'll stir up the joint. They put it in more during the day until things calm down and then go back to nighttime. It is too simple. And the reason that the device is designed like this is 90% of the loads on these joints come from the posterior teeth. So you only have to disocclude or separate the posterior teeth according to the protocol. You don't violate the protocol with a device that you can speak with, that you can talk with. You just can't chew with it in your mouth. So when it comes time to eat, you take it out. After you eat, you brush your teeth, you put it back in. That goes on for the first 2 months, and then after the first 2 months, then you go to nighttime the rest of your life. And that protocol works just like that protocol in the majority of the bell curve. 85% of the patients. There are two tails on the bell curve, and some patients, and the ladies come in for the years, I'm well familiar with it. I figure it out when I'm in traffic. I figured out when I'm sitting on the computer, I put this thing in my mouth. I hear that fairly often, or some rendition of that. So I have been watching the number of live viewers on the screen. If you see me looking up to my right periodically, what I'm doing is not looking out the window. I'm looking at the number of live viewers and invite anyone to ask questions. I'm going to wrap it up. If I don't get any questions, we're going to wrap it up, and I'm going to go see my grandson, Anthony, play football. Not seeing any chat. Give another 30 seconds to see if anyone wants to ask a question, make a comment, or make a criticism. I do these live streams giving viewers and my colleagues the opportunity to comment directly with me. There's no question you can't ask me that I won't answer. None. Ask me any question, I promise you I'll answer it about this disease or any other thing really. It's like I've been a maxillofacial surgeon too long. I just have too many miles under my belt. I feel pretty comfortable in my own skin. And I like to communicate with other people. And I really, as I said earlier, I am on a mission to get this problem solved. For those of you who are patients who have this problem, you want to find out more about it, or you want to find, if you're in Middle Tennessee or somewhere near here, you can come see us. But there are now doctors in 20 states who are licensed to use this device and protocol. That information is available on our website, which is www.urbanektmj.com. I spell my name Urbanek, U-R-B-A-N-E-K, T-M-J, Tango Mike Juliet.com. And for the doctors who would like to do this and help patients simply, not complicated wise, same website, urbanektmj.com. You'll get access to how to find out how to take our course. There's a 3-hour online course that you need to take to be qualified and licensed to use this patented device and protocol. Take the course, you're licensed, and then you can provide the same service that I provide here in Middle Tennessee to treat patients with temporomandibular joint disorder in a real way, where the results are long-term, as long as the patients use the protocol and the device. You'd be surprised the number of people, they're doing well, I'm doing so good, I quit using the device. No, that isn't what we said. You can't do that. You can't do that. It's like some patients just want to do what they want to do, as like some doctors do what they want to do. That is for sure. All right, with nothing in the chat, I'm going to wind it up. I look forward to next Saturday at noon, where we're going to open this up again for anyone who wants to find out more about TMD Demystified. I'll pick another topic to talk about. I enjoy doing it, And hopefully maybe next week we'll get some good questions. I encourage you to tell your friends if you have a friend or a family member that has this disease. Remember, 1 in 6 females have one or more of those symptoms of temporomandibular joint disorder. Tell them to come in on Saturday at noon. I'll be happy to discuss it with them, answer their questions. But for today, we'll wrap it up. I am Tony Urbanek, and this is TMD Demystified.